Hi, my name is Danielle Holdren, and I am a fourth year pharmacy student at VCU School of Pharmacy. Currently, I am completing my APPE elective in digital health, and so very excited to share my project today focused on vancomycin AUC-based dosing in obesity. And so just to give a little bit of background on vancomycin, this is a glycopeptide antibiotic that does primarily work by inhibiting bacterial cell wall synthesis. Vancomycin is only indicated in gram-positive infections, and so our organisms of concern here are going to be our enterococcal species, our strep species, and our staph species. And that includes our methicillin susceptible or Staph aureus and our methicillin resistant Staph aureus. And of note, MRSA is commonly implicated in our more serious infections such as bacteremia or bacteria in the bloodstream, endocarditis or infection of the heart, or even osteomyelitis, which is infection of the bones. So some of those more serious infections, vancomycin is very effective at resolving. And so vancomycin is a time-dependent antibiotic, which I will get a little bit more into this with our background, but this essentially means that it works best when it is maintained at a certain level for a certain amount of time. And then biggest thing to note here is that vancomycin, while very effective, is actually associated with a narrow therapeutic index. And so essentially that means that there is a very small window in which we have to keep our vancomycin levels in order to avoid either toxicities on one end or just therapy failure on the other end. And so, because of this narrow therapeutic index, we are required to do therapeutic drug monitoring with this drug to keep track of the levels in the body. And so, giving more background on the PK, the primary parameters that we're looking at with our vancomycin monitoring are going to be our minimum inhibitory concentration, our peak and trough levels, and our area under the curve. And so if you'll look here to this diagram on the right, we see each of those variables kind of spelled out. So our MIC is going to be that minimum concentration at which vancomycin has to be maintained in order to exhibit that inhibition that we talked about with its mechanism. And so then our peak is going to be the highest level of vancomycin that is reached in the body, and that typically occurs just a couple of hours after administration. And then on the other end, our trough is going to be the lowest level of vancomycin that we'll see reached in the body, and that typically occurs right before the next dose. And then our AUC is just the area under the curve, or the total amount of exposure that we're going to see of vancomycin in the body. And so there are a couple different kinds of therapeutic drug monitoring that can be performed for vancomycin. So the one that we have really relied on for the past decade or more has been our trough-based therapeutic drug monitoring. And so this is really taking our trough levels and using them as a surrogate marker or measure of our AUC level. And so basically that process involves obtaining a blood sample just before our fourth dose of vancomycin. And as that's going to be the most accurate trough that we'll get. And then if that trough is within this 10 to 20 range, then that is enough for us to assume that our AUC is is within that therapeutic window that we need it to be in. And so they actually did come out with some revised guidelines in 2020 that unfortunately found that our trough-based dosing is actually not as accurate as we had assumed. And so they found with this recent research that there is actually a lack of a strong correlation between our trough and our AUC, in which our trough actually underestimates a patient's true AUC value a good percentage of the time. And so the recommendation for AUC guided dosing came from research that showed that the AUC guided approach was actually accurate in about 97 to 98% of the time, which is a pretty significant difference. And so with this new AUC-based monitoring, we will just obtain a couple more levels. So we'll get a peak level to see that peak in our blood, and that will be typically 1 to 2 hours after the start of the infusion. And then we will also get our trough level per usual before the 4th dose. And then we will take those levels and we'll plug them into our first order PK equations to estimate our AUC. And the AUC window that we want to keep our patients in is that 400 to 600 range. And so kind of extrapolating this further into the obese patient population, the recommendation was only centered around our standard population. However, research from Massage actually developed a novel dosing scheme that would take into consideration the pharmacokinetic changes that might be happening or might be altered in our obese patients. And so why is this important? Our special populations often will have altered PK, which means that the way that the antibiotic is going to distribute or even work in the body can be altered from what we would typically see. And so some of those parameters that might be different might be the volume of distribution. We might have higher free drug concentrations, meaning that more vancomycin is doing things at other sites. And we might have altered kidney clearance. And so the relevance here and why this is important is that ultimately we want to optimize vancomycin dosing. Because of that small therapeutic window, by optimizing dosing, we're going to prevent those toxicities, but also prevent the over-treatment that might happen if we're not reaching our therapeutic levels. Ultimately, that would result in improved patient outcomes. We would decrease our length of hospitalization. We would increase our time to recovery. And so all those things would be affected there. And then on the other end, from an antimicrobial stewardship standpoint, this could help prevent or decrease the rate of resistance that is occurring to vancomycin, because by exposing the patient less to the drug, then that's less time that our bacteria have to develop those resistance mechanisms. And so from that, this is where I decided that based off of Massage's research, I wanted to create a calculator that would kind of incorporate that novel PK equation that she was able to develop and streamline the workflow where we will be dosing these patients in a clinical setting. And so using KNIME, which is a free analytics platform, I was able to create a calculator with the inputs that are necessary for our AUC estimation. So I will walk through here. In KNIME, we are able to use different nodes that incorporate different coding into them. And so from that, you are able to essentially build a workflow of different functions and connect it together. And so I will start here by just showing from my workflow that I was able to create a interactive dashboard or an interactive calculator. And so with this, you can see here, this is like a functional calculator. I've got it split up into a few different sections, but basically taking our patient baseline values and just plugging them in as they come in. This allows us to calculate in a real-time manner to find these parameters for our patients. And so here of note, the calculation is going to be our creatinine clearance. But we also have a BMI calculation to kind of see what level of obesity are they at. And then we also have our maintenance dose calculation here. And so from this information, we are able to then come down to our AUC estimate. And with that, it allows you to input whichever dose that you want to start with. So we might want to start with 3,000 for this patient. And so from that, you are able to then plug in each of the parameters that you're going to be using with your dosing scheme. So how often are we dosing them? How long will the infusion be? And then once we get those peak and trough levels, we'll plug those in, which will all go into our estimation of our AUC. And so once we calculate here, the calculation of note is our AUC estimation. Again, we want it to be in our 400 to 600 range. Other notable calculations here are our clearance, our volume and distribution, all patient specific, our true trough and our true peak, which we can find they can vary slightly from the samples that we collect, and our elimination rate constant. All of these are important PK parameters that we're going to use in our first order calculations. And so I will then go more into my calculator to kind of break down the flow of how I created this workflow. And so I'll start with actually our patient baseline inputs, our initial maintenance dose. And so going further into this, looks complicated, but it's actually fairly easy to follow. So with our blue nodes here, these are really all of those components that are going to go into creating that visualization, that interactive dashboard that I just showed you. So right here, these are all of our patient inputs. And then following this node here is basically allows us to decide if we have a male or a female, what route of calculation we're going to take. Mainly because our calculation for creatinine clearance does vary between the two, but the steps are very similar. So just making that slight change to account for our gender. From that, we are also able to go onto our BMI calculation, which is a simple just plugging in the calculation, which the computer will then calculate out. And then down here, we have our maintenance dose, and that's the range that I provided in that table. And so same thing down here with the females, and then all of that will come out here and be presented in that table tile view with all of the inputs and all the calculations that we got in this step. So then I will come all the way back to here to our AUC estimation and go further in detail to those calculations. So similarly, these blue nodes were used to create that interactive dashboard, so allowing us to collect those patient inputs. And then the main thing here is our first order PK calculations. That's everything that is incorporated into this specific component. So again, we will calculate our elimination rate constants. We'll get our true peak and our true trough. From that, we can calculate our volume and distribution, our clearance, and then finally our AUC estimate. Again, all of that will be outputted in that tile view where the patient's data is compiled together. And so it's fairly easy to follow. You can see where step by step the calculations are coming from. However, I think that the most difficult part of doing these calculations in practice is that each of these steps is typically done by hand. There's not a lot of automated methods to doing this. So this workflow really takes what is normally a complex process and condenses it into simply inputting patient variables. And so after we are done with using the calculator, we are actually able to output a report of the patient's values. And so here, this is everything that we calculated with the calculator, but it is condensed together. And so that is nicely done there. And so just moving further with my project, I do still have a few things in progress. This is something that I'm going to continue to work on after I get through with this rotation. I'm really hoping to turn it into a longitudinal project where I will be actually working with Massage to further optimize this calculator. And so I'm looking to incorporate a method for data collection. So instead of calculating one patient at a time, I'm going to make it to where while you can do that, that patient's info is going to go kind of into a database or an Excel drive or whatever so that we can calculate it, or sorry, so that we can collect it, and then from there potentially view any trends or any differences that are happening across patients. And so additionally, I would also like to clean up some details with my dashboard, specifically with those tile views and just removing unnecessary features that really don't do anything for the interactivity. Also, just making it more visually appealing with different colors, the font, bolding, things of that such. And then incorporating more interactivity, especially as we go to that method of data collection, having a way to compile tables and make those more visually appealing as well. And then lastly, with my BERT, or the report that I showed at the end there, I am hoping to go ahead and incorporate some of those, well, all of those equations that I used in the workflow. That way, if a pharmacist or a clinician is doing this, using this calculator, if they want to go back and double check manually, they can have all those equations that are kind of embedded in that calculator that they can do themselves. And so here are my references, and that is my vancomycin AUC-based dosing calculator for our obese patients. If you have any comments, questions, concerns, definitely don't hesitate to email me at this email address below. And thank you for your time.